Okay, we're going to take a look at home sleep testing. These are all different terms that describe the same thing. These are all home sleep testing: portable monitoring, HST, home sleep testing, home monitoring, limited channel sleep testing, and out-of-center sleep testing. Depending on which group of people you're talking to, they may describe sleep testing in different ways. For example, the Centers for Medicare, they have different terminology for the test than the AASM. The AASM has levels 1, 2, 3, and 4, which are slightly different than Medicare description. And the Medicare has these special codes for reimbursement. A level 1 is an attended sleep study. This means it's in a sleep lab, a normal one, the one that we do. Level 2 is not attended, and in this situation, either the tech would go to the patient's house and hook them up with portable equipment and then start it, or they would hook them up in the lab and then send them home to start the test right away, because this one does include EEG. Level 3 is the most commonly used type of portable sleep testing right now. It monitors both airflow at the nose and mouth as well as respiratory effort, and then it also monitors heart rate and oxygen saturations. And then the level 4 is the most minimal of all. It monitors oxygen saturation and either flow or chest movement. Here's an example of a portable monitoring device, a type 3, and you can see the nasal pressure transducer, the oral nasal thermal flow, the thoracic and abdominal rib belts, your SpO2, your heart rate, and then your body position. In this example here, we see a hypopnea, and remember, we use our nasal pressure transducer channel to identify that. And you start where you see a clear decrease by 30% in the waveform, which I see right here. I would end this event right here, because here it looks like it goes back to baseline breathing. My oronasal thermal airflow signal on this example is horrible. You can't really identify anything, so it would be really hard to identify an apnea with such a poor signal. And that's one of the risks you take with portable monitoring, is you can't go in and fix that. You have to work with what you're given. The process for ordering portable monitoring: the treating physician who orders the study must perform a face-to-face evaluation. In the evaluation, they need to do a thorough sleep history and review of the patient's current symptoms. They need to evaluate an Epworth Sleepiness Scale, as well as a physical exam documenting the BMI, neck circumference, as well as a cardiopulmonary and upper airway evaluation. The requirements for diagnosing a patient with portable monitoring: this isn't different than a normal sleep study, because all sleep tests must be reviewed and the test must be interpreted by someone who is a physician. Here it just outlines exactly what types of physicians can do it. Basically, they either need to be a member of the American Board of Sleep Medicine, or a member of the American Academy of Sleep Medicine, or a staff member of any Joint Commission accredited sleep laboratory. So again, your sleep physician needs to review all the raw data. Portable monitoring really didn't even show up until about 2005. And then in 2008, they finally accepted 3 of the types of home sleep testing. They accepted it to qualify a patient for CPAP. Not necessarily that they would pay for that test, the home sleep test, but it would qualify them to diagnose and order the CPAP. In 2009, they increased the types of qualifying types of home sleep testing from 1, 2, 3, 4, and PAT devices. So they said, now we will reimburse and we will allow patients to qualify for CPAP with that. And then finally in 2011, the AASM finally published some standards for out-of-center sleep testing. You can tell they changed the terminology over the years. So when we talk about the differences between an in-lab sleep study and a home sleep study, granted, we're looking at a lot of the same data, but there are some very specific differences. For example, when we talk about the AHI, an AHI in a gold standard study performed in a sleep lab is going to have more accurate results, and most likely it will have a higher AHI compared to portable monitoring, and we're going to take a look at why. So with the home sleep not a home sleep test, with the in-lab sleep test, we calculate the number of apneas and hypopneas, and then we divide that by the total sleep time. And this is the time we actually know they're asleep. So in a in-lab sleep study, maybe the patient slept for 5 hours, and using home sleep testing equipment, it maybe would only it would gather 6 hours, because with the home sleep testing, you can't tell when they're awake or asleep. You actually start your recording time when they say they're going to bed, and you end it when they get up. So maybe a patient actually spent 6 hours in bed, but out of that 6 hours, they really slept only 5. So if we do the math for that, using the same amount of events, so if the patient had 60 events and they only slept for 5 hours, the AHI would be 12. In contrast to that, if it was using home sleep equipment and it didn't identify that for an hour the patient was awake, then you would have an events of 60 divided by 6 hours, and the AHI would be 10. So obviously, in-lab PSG will have a higher AHI and more accurate. The patient may have more supine sleep in the sleep facility than at home. That's just something they have found. And then they've also found that less technically adequate recording time with the portable monitoring, meaning they just capture fewer events. When the AHI is lower in the sleep lab compared to the AHI at home, the reasons why or if this might happen is maybe the patient had more REM sleep at home, maybe because their environment was more comfortable. The patient maybe drank alcohol at home where they wouldn't in the sleep lab. Or maybe the respiratory events were scored when the patient was awake. Maybe they were holding their breath or something. Outcome studies using portable monitor. Rather than comparison of the AHI of a standard sleep study and a portable monitoring, the clinical utility of using portable monitoring versus in-lab sleep studying for the diagnosis of OSA is the main issue. Does home sleep testing versus in-lab sleep testing result in worse OSA treatment outcomes? Well, what they found is most outcome studies use unattended auto-PAP followed by CPAP treatment in patients diagnosed as having OSA. In-lab sleep studies and home-monitored sleep study pathways resulted in equivalent or better PAP adherence and improvement in the subjective sleepiness. So let's, I could go through all the advantages and disadvantages of home sleep testing and in-lab sleep testing, but those are pretty obvious. I mean, cost is one, comfort is another, so on and so forth. So I think you guys can logic that out, but let's talk about the limitations. So the limitations of an unattended sleep study, meaning a home sleep study, it has the potential for monitoring leads becoming unhooked during the study, which leads to an inadequate study. And 3 to 5% of the studies actually are inadequate and have to be redone. The total sleep time and the amounts of different stages of sleep are not documented, so we have no idea if the patient actually got enough sleep. We have no idea if they even got REM during the monitoring time. Again, the AHI is calculated by adding the apneas and hypopneas and then dividing by the monitoring time, which can result in an underestimated AHI. And we already worked through one example, but here's another example below for, if a patient had 200 events from 4 hours versus 6 hours, you can see that's a pretty significant difference in their AHI. Still severe, but. Some other limitations, it may not determine the amount of supine monitoring time. Again, you just would have no idea. Some patients are very anxious about becoming disconnected without someone available for reconnection, so they may not sleep well because they're kind of worried about that. There can be device loss or damage, which then you end up eating the costs at your sleep facility. Good quality home studies require trained personnel, and they do have substantial costs. Some of the costs come into play with paying for the tech to educate the patient correctly and thoroughly, setting up equipment, downloading it, cleaning the units, analyzing and preparing the reports. Overall, the cost of home monitoring is less, but they also get less reimbursement. The need to perform in-lab sleep studies for negative studies occurs mostly in sleepy patients. If diagnosis of significant sleep apnea is made, you still need to perform an in-lab CPAP titration in most patients, unless a non-PAP treatment or alternative PAP treatment approach is used. Some of the alternate approaches include auto-PAP titrations and auto-PAP treatment, as well as an empiric CPAP level. So auto-PAP titrations are becoming very popular. Unfortunately, some people are also doing auto-PAP treatment, meaning they set up the device to perform auto-PAP, and then they just leave the patient on the auto-PAP. They don't even set up a CPAP setting for continuous use. They just leave them on the auto-PAP device. Empiric CPAP level, I've had some physicians who strongly believe in this, and then they have the patient go home with this for a while, and then after about a month, they bring them back into the sleep lab and they do a full study. And so an example of this is maybe you had a patient with moderate sleep apnea and they had a slightly high BMI, but they were not significantly obese. The physician may say, let's start them at a CPAP of 7 because that's a common pressure, and send the patient home for about a month on that pressure and then come back and do a full titration. And the reason for that is it gives patients time to acclimate to their pressure in their own home, kind of work out some of the troubleshooting there on their own. So when they come back for titration, they usually do much better. The downside of that is the patient could easily get frustrated with the CPAP at home and quit using it right away, and so on. A face-to-face evaluation may identify a substantial proportion of patients that are not good candidates for portable monitoring. So the AASM clinical guidelines for unattended portable monitoring in adults, their recommended methodology is that portable monitoring must be performed in conjunction with a comprehensive sleep evaluation supervised by a sleep physician. That's a board certified or credentialed sleep physician. No portable monitoring in patients with comorbid medical conditions that may degrade portable monitoring accuracy. Some examples of this are severe pulmonary disease, neuromuscular disease, or congestive heart failure. No clinical suspicion of other sleep disorders for which a in-lab sleep study would be indicated. So if you have any suspicions of central sleep apnea or narcolepsy, periodic limb movement disorder, parasomnias, or circadian rhythm disorders, any clues of that would rule out the indication for doing a portable monitoring. You shouldn't use it as a screening tool for patients who don't have any symptoms, and then unattended portable monitoring in patient's home is acceptable when all guidelines are followed. Choosing a patient for portable monitoring, all of this information, by the way, that I'm going through, it's all in your fundamentals textbook. This is all in there. I've just reorganized it and talking you through it here. When you are choosing, or when the physician is choosing a patient for portable monitoring, they're going to start with a clinical evaluation and identify that there's a reason to do a sleep study. Again, we do not use it as a screening tool. You shouldn't say every patient above the age of 30 I'm going to do a home sleep test on. Like, that's just an appropriate use of it. They need to have a complaint. Does the patient have a high probability of moderate to severe OSA? If they do not have a high probability of moderate to severe OSA, then they probably need to do a standard sleep study. If they do have a high probability of it, then the next thing you need to consider is, do they have a medical comorbidity? If they do, they need to do an in-lab sleep study. Those comorbidities that we're talking about is moderate to severe lung disease, neuromuscular disease, or congestive heart failure, hypoventilation, a low SpO2, they're already on oxygen, or they take high-dose narcotics. Now, last quarter, I had a case study where somebody had hypertension, and someone asked, well, why didn't that person need to have an in-lab sleep study? Well, it's not a significant enough comorbidity. They would need to have other conditions in addition to just the hypertension. Now, the hypertension, along with symptoms of excessive daytime sleepiness, those are clues to have a sleep study done, but not necessarily that they need to have one done in a sleep lab. So if they do not have a medical comorbidity, then you want to consider, do they have another sleep disorder? If they do, again, that's a reason to do an in-lab sleep study. If they do not, then they can go ahead and do a sleep study in their home. Here's an example of a a level 3 portable monitoring device. This is actually Embleta by Embla. And one thing that this has is, here's your nasal flow, here's your thermistor, here's your thorax, here's your abdomen belt, and then they have this X-flow. X-flow is a signal obtained by taking a sum of the thorax and abdominal respiratory and ductus plethysmography tracing. So it takes a sum of these two. And then the illustrated events are a estimation of what the equipment believes is occurring based on the sum of these two events. In the picture we have here, these are central apneas, and it actually chain Stokes, because you can see they gradually get bigger breaths and then they get smaller until they cease breathing, and then they slowly start to build, get bigger breath, biggest breath, and then they decline again. So we call that waxing and waning. Here's an example of a home sleep study report. Notice it is pretty basic, like compared to what we see for in-lab sleep studies. This is just like hardly anything. Some things to pay attention to. You have your start study time, your end study time, and then your total study time. Percent of REM sleep time. This is an estimation because I really can't tell off of the study results. You have your mean saturation, minimum, and maximum, and then they say how many saturations or desaturations they experienced. As far as oxygen desaturations, they add up the number of times that the patient had oxygen desaturations. Over here, they have the REM, RDI, AHI, and ODI. So based on the PAT device, they're identifying respiratory disturbance index versus the apnea-hypopnea index, and then the ODI is the oxygen desaturation index. And based on what they assume is REM sleep time, that's how they got their non-REM compared to all night. So these are all just calculations that they're using to come up with these things that are built into the equipment. And then you can also see they have their heart rate here. So a lot less information. Here's an all-night summary of the results from a WATCH-PAT 200 study. A hypnogram right here, where it is doing some sleep staging, excuse me, as well as you have your oximetry here, and then you have your body position here, as well as your respiratory events here. And based on these results, here's REM, here's REM, here's REM, and here's REM. And if you compare that to when they're having respiratory events, you see a high correlation of the respiratory events, oxygen desaturations, and REM. Another thing I always look for is supine. So supine is, boy, let's see. All of this was supine. They actually had maybe a few more events supine than they did non-supine, but predominantly the events were during REM. If a portable monitoring test is negative for sleep apnea, there's some things you should consider. A false negative home study must be ruled out given moderate to high clinical suspicion of sleep apnea is in patients studied with portable monitoring. Excuse me. Sorry about that. After a home sleep study, questionnaire should be performed, which asks the patient about how long they think they slept and how good do they think they slept. If the patient states, I don't think I slept very well, or man, I didn't sleep as long as I normally do, anything like that, that could be the reason why they have a negative study, because the more time they're awake, the fewer events they're going to have. And remember how we talked about how an AHI is going to be more accurate in an in-lab study. So it's very important to always ask the patient about their sleep. You may need to either repeat the study if they didn't get a good sleep, or the doctor might say, just bring them into the sleep lab. In some cases, this says in most cases, and I would disagree with that, in some cases an in-lab sleep study is needed. Sometimes they will just repeat the home sleep study if they think it's technically inadequate, or they could do an in-lab study, but a lot of times they know insurance isn't going to reimburse based on the patient's insurance company, so they'll just re-perform the study in home. If the patient has been found to have mild OSA, typically they consider non-PAP treatment for it. If they do have moderate to severe OSA, then PAP treatment is the treatment of choice. They will typically do a CPAP titration. However, more and more we're seeing the auto-PAP titrations at home, or just people putting a person on auto-PAP and leaving them on that as their treatment. I disagree with that, but we're seeing it more and more. So here's the pathway that we'll walk through for a patient who has had a home sleep study. So the home sleep study is performed. OSA is not present. Okay, let's do an in-lab sleep study. If OSA is present, then we have to ask ourselves, is the patient's condition complicated? When we say complicated, this is what we're talking about. Did we see central sleep apnea? Did they have Cheyne-Stokes breathing? Do we suspect hypoventilation? Did they have very severe oxygen desaturations? Do we know that their insurance company doesn't provide reimbursement very well? Do we know that they have a low baseline SpO2? Or is there a likely need for high PAP? If that's the situation, then they need to do an in-lab sleep study. If the answer to this is no and they do not have a complicated situation, then they can do the auto-PAP treatment, the auto-PAP titration, then followed by a CPAP treatment. Again, the empiric CPAP treatment, again, that's when they guess, basically. Or they can do in-lab sleep PAP titration followed by PAP treatment, or they can opt to do non-PAP treatment. So those are all the different pathways. Okay, follow-up for portable monitoring is the same as with in-lab sleep studies. You need to do early contact after they have their PAP at home, make sure they're using it right away, address any issues they're having with it, offer support. You're encouraging them, you're helping them identify how it's going to help them in the long run. If they have unresolved symptoms, then the disease management team really needs to evaluate the problem and be involved. Is it an equipment issue? Do they have a poor fitting mask? Do they need humidity and so forth? Once resolved, long-term follow-up process is initiated or resumed. Is it a medical issue? Do they have nasal congestion or something else going on, headaches? Again, once it's resolved, long-term follow-up process is initiated and resumed. Or do they have persistent EDS? If that's the case, then they need to rule out the adherence. They need to rule out if the patient is not spending enough time sleeping. Are they having pressure leaks? Do they not have enough pressure? Do they have another sleep disorder? So lots of things to consider, but the entire management team needs to be involved. Okay, this is an excellent question you all need to be aware of. You need to know this answer. Monitoring adherence is required for reimbursement from some insurance providers, for example, Medicare and Medicaid. A lot of times, whatever Medicare and Medicaid does, then Blue Cross and Blue Shield follows suit. So Medicare and Medicaid requires a minimum PAP use of 4 hours per night for 70% of the nights for at least 1 month for them to reimburse. So those are magic numbers. 4 hours, 70% of nights, 70% of nights for at least 1 month. If you can prove that your patient is doing that, they will usually get reimbursed. All right, that concludes this video.